All right, welcome into Paw Patrol with your host, Dr. Jeff Dykes. Tonight, I'm joined by Dr. Nick Campitelli. Thank you so much for joining me.
Of course, man. Thank you for having me. I'm excited to do this. I've been trying to get onto your podcast for over a year now, so I'm honored to be here.
Absolutely. I'm excited to talk with you. Let's jump right into it. But before we do that, why don't you give people a quick little background of who you are and where you practice?
Sure. Yeah, my name's Dr. Nick Campitelli. I grew up in Pennsylvania and went to Slippery Rock University, if anyone listening has heard of that. And then I did
hmm
my podiatry school at the Ohio College of Podiatric Medicine, which is now Kent State.
hmm
Did my residency at Mill Creek Community Hospital in Erie, Pennsylvania, where then I practiced for 2 years. And then I moved to Akron, Ohio, where I now practice in a group setting in Unity Health Network. We're an Optum managed organization. We have over 150 docs in our group. There's 3 podiatrists. I am a residency director for Western Reserve Hospital, which is the residency program that takes one a year. And I am a social media person, I guess I would say. I love social media. I started out about 8 years ago trying to, I guess, share what I do in the office and in the OR to help students and residents. And it just kind of blossomed from there. And maybe we'll talk about that a little later today. But I guess
Yeah,
that's it from me.
absolutely. We will definitely dive into all that stuff. So, for the students listening, I think it's always interesting to hear from residency directors because, yes, they can go on an externship and get to know you, but it does help that for them to know that you exist in the first place. So, for any of the students that are listening, you want to talk a little bit more about your residency program. You say you take one per year. You're in the Akron, Ohio area, and you want to kind of talk about what residency is like for those who go there.
Yeah. So our residency is based out of Western Reserve Hospital. And it's a community hospital. I'm bad in terms of the number of beds. We are a level 2 trauma, so we do get foot and ankle trauma that comes in, and that is most of that is done by our foot and ankle orthopod, Dr. Amy Tucker, who is very podiatry friendly. She works with us. Most of our third years will scrub her ankle cases, and they get well above the minimum required number for trauma cases. And then there's about 10 of us in terms of attending physicians. And we have what I like about our program is it's very intimate and well balanced. So you'll spend a lot of time in my clinic. You'll see my patients from start to finish in terms of what we're doing surgically. If you saw them in the office, you'll definitely see them for their case and then postoperatively. We have a wound center at our hospital that we work one on one with our residents. We take 2 clerks a month typically, and we also have third year students that come through our program.
Hmm.
So, it's great. We have a lot of education happening. We do didactics weekly. Those are on Thursday nights. They're virtual. They're growing. We offer one CME credit. So, any of you post grad residents that are out there and you live in Ohio, you can get one CME if you want to join in. So, you can certainly find me, reach out to me through email. I'm sure Jeff will post a link on how to reach me. And we'd love to have you join. We have great discussions. They're very academic focused, meaning we break down McGlamories just for a topic, and then we review 2 articles each Thursday night, and it goes a
Hmm.
full hour, and we
Mhm.
have some great discussion.
Those are really good for the students and for the residents because, McGlamories is the all-encompassing textbook. Every little detail that's ever existed on a certain topic is included in there, and it gets a little tedious. But if you know all of that stuff, then you know everything. And then I think spinning that into tying in some articles to kind of update that, I think is a good way to do it.
Oh, 100%. Here's what we did, Jeff. We sat down and said, over the next 24 months, we're going to review these 24 chapter well, it's more than that because it's weekly. We're going to view these chapters. Some of
Mhm,
them are we regroup multiple chapters together. It just depends on if they're large or small.
mhm.
And then you're right, we're hitting all of those points that we really typically wouldn't do. And sometimes didactics gets, if you don't have an assigned topic and it comes time for didactics and you're scrambling to put something together, now we know for the next 24 months, and then it repeats after that, what we're actually looking at. And then we do 2 journal articles each week. It's not a journal club like where you would typically in depth review the article. It's, hey, here are 2 articles that are relevant. Let's review them quickly. And then that's when you think about it, that's 8 articles a month we're reading. Sometimes, if you don't do that, you're not forced to look at an article. You might not look at something the whole month.
Yeah, and I think that's a great way to do it, like I said, because it forces you to end up looking at the things that are less popular. Meaning, if you just pick a topic, hey, you pick the topic next month. Oh, I pick ankle fractures. And then the next month, oh, I pick calc fractures. What do you want to do
Right.
after that? Let's do ankle fractures again. Like, okay, we know everything about ankle fractures, but we're not talking about, second MPJ pathology and Taylor's bunions and, you know,
Exactly.
extensor substitution, the things that aren't as glamorous to talk about, but are very important. So I think that's a great way to do it because it ends up making you fully well-rounded, whether there may be weeks that you're not as excited about it, but at the end, you're going to be fully versed on all the topics that you can be.
Right. And our residents it wasn't mandatory for them to present. Now they have to present an hour every week. So it's rotated and I will present one of those each week or each month as well. But it gets them practice in presenting. And some of them are really, as the year goes on, it's amazing how good they're getting at presenting in front of crowds. And that's what they need to do. They need to be well versed in giving lectures.
We did that a lot at my residency. So by the time we got out, we were very comfortable speaking in front of an audience because if I
Hmm.
can speak in front of Dr. Burns, Dr. Manway, Dr. Wukic, and some of the orthopedic faculty, then I could speak in front of anyone because that can be an intimidating situation. So to put yourself up there, put yourself on the spot and get used to it when it is in a somewhat controlled environment is actually going to benefit you when you get out into the real world, especially if you are someone who may be interested in presenting on a more global or national scale, I should say.
Right.
So, what are some of the favorite cases that you do there? Obviously, you're the director, and that makes you one of the attending surgeons who the residents are going to scrub cases with you. What are some of your favorite cases that you like to do?
So I think my residents and students will tell you that I have a lot of passion for what I do and I get excited about everything. So whether it's an ingrown toenail in the office, a ganglion cyst in the office, an ulcer, we're always filming it. I'm always excited to teach or say, this is how we're going to remove the side of the toenail. And I know that sounds elementary, but I've had third year residents that came to my office and didn't know how to do an ingrown toenail properly because they're in the OR all the time.
Hmm.
So from just that small aspect of podiatry to my favorite thing in the OR is obviously minimally invasive bunion surgery, which I kind of got started with early and have been doing it now for 6 years. Not to plug Arthrex, but as a disclosure, I am a consultant for Arthrex. So I've been going to that campus for the last 5 years teaching and educating in their minimally invasive courses. So I'm very passionate about minimally invasive surgery. Charcot reconstruction, which I really wasn't when I first started in practice, I didn't do a lot of it, and now we're doing a lot of it where we are just because those cases are coming through and coming in, and I've
Hmm.
grown to love it because it's fun and it's rewarding because a lot of these patients, I don't wanna say they get pushed around, but they go to a wound center, and if they're seeing a podiatrist, that's great, but sometimes they're seeing nurse practitioners or general surgeons that don't do reconstruction, and if they don't do the reconstruction, they don't know to offer it to these patients, so
Yeah.
they've been falling into our lap, and we've been doing a lot of Charcot reconstruction lately. So, but we do everything from A to Z. There's ankle replacements are done at our hospital through Dr. Bennett. I will typically fuse an ankle. I'm trained in replacements, but I like fusions better. So the residents get their training in ankle replacements from Bennett, who's a foot and ankle orthopod. And again, I say podiatry friendly, but they are because they work closely with me and they know how I'm training the residents. So they're excited to have the residents scrub with them, and it's an intimate community. I like to sleep at night, so I'm not taking on things that I'm not comfortable with, and I think they appreciate that.
Yeah, I feel the same way. I do hate bunions and Charcot, so I'm the yin to your yang. So you love those two things? Those are like my least two favorite things. The Charcot patients are so complicated. My wife does a lot more Charcot reconstructive stuff than I do, and I commend anybody who tackles that stuff because it is an uphill battle for these patients, and it could sometimes be a mess. And when you win, sometimes the win is temporary, but you're just fighting the good fight day after day to try to keep that limb and keep them upright and keep them mobile. So anybody who tackles Charcot, I commend them. So that's probably the most complex thing that we do because it's attached to the most complex patient.
It's they say 50% of them fail. And you're right. When you win, and it's how long did you win? Because at some point it's going to happen.
Hmm.
They are complex, but I think like anything in life, you think it's complex when you see other people do it. and then you do it, and then you reflect on what you saw other people do, and you're like, well, that wasn't as bad as I thought it was. And now that I look at how they did it, I think I did it a little bit. I don't like to say better because I don't like to compare myself, but
Hmm.
sometimes you think, well, I helped the patient, I
Hmm.
mean, maybe I did something a little bit differently, which might give them a different outcome. So
It's a tricky patient population for sure. You
definitely.
mentioned Arthrex. There are worse places in this world to go than Naples, Florida. That place is beautiful. I've been there before, and that's a
It
fun
is.
place to go.
It is a playground, the world's greatest playground, I feel like, for surgery. I'm very fortunate to be able to go there and work with them and teach. And I guess when you're there and you're excited to be around other people that want to learn. Sometimes when you're in environments that are similar, that people aren't excited to be there, it's different. So I'm very fortunate to be able to go there and teach. It's fun.
Yeah, they obviously have a vested interest in their own products, just like every other company has a vested interest in their own products. But when you go there to learn, it certainly fosters an environment of education and shared knowledge that is highly beneficial for the people that go there. It
Mhm.
doesn't necessarily just feel like a one big advertisement. They get the people there that are sharing ideas and bouncing thoughts off of each other. And I think it feels more collegial and highly educational. So, and that's
Mhm.
ultimately what people benefit from.
Right.
So let's switch gears here to talk about your YouTube fame. Would you call yourself YouTube famous? What how do you like what's the level before you're like YouTube famous? Like is there a level?
I don't think I am because I compare myself to some of my friends that are entertainers. And when I say entertainers, I kind of got started with this through a friend who's a magician, and he's known worldwide. His name's Rick Smith Jr., and he's a playing card. Guinness Book World Record holder. He throws playing cards and cuts celery. And I know this isn't the topic of what we're supposed to be discussing, but
Right.
that's kind of how I got started. So I'm comparing myself to him and his friends in that arena. And my son is an editor and he's involved with a lot of different YouTubers. So I don't see myself as being YouTube famous. I don't know, maybe in the podiatry community, some people, but I don't know who sees me. So I don't know what podiatrists are watching my videos. I just recently lectured in Tennessee for their annual scientific conference for their state, and it was on social media, and I was amazed to see that they knew who I was.
Mhm.
So it is cool to see that people are watching my videos. And the goal, Jeff, when I started this was well, it was twofold. When I initially started it, it was to show educational videos to the residents so they could watch surgeries and learn from the surgeries.
Mhm.
And when I did it, I said I didn't want to just put surgeries out there. I wanted them to be the best. I wanted them to be the clearest. I wanted them to have educational content. I wanted a resident to be able to watch that video and then go into the OR and say, I know how to do this now because I watched your surgery. That was the goal.
Yeah.
And then it evolved into doing videos that students would watch in the same manner. And then once short videos became, I just started doing everything in above. And I've kind of morphed long form surgical videos into shorts. But my favorite is to still do those long form surgical videos. And I
Mhm.
remember one time I was at Arthrex teaching, and one of the consultants who I look up to leaned over to me up on the panel and said, Hey, thanks for uploading that common perineal nerve video. I hadn't done one of them in a while, and I watched your video and it helped me. And I'm like, that's why I do this. That it's so
Yeah.
cool to have others watch it and learn.
Yeah.
And, you know, it's on a platform that's free. When I was a resident, we used to pay like $50 to get a video on bunion surgery that was terrible. And now these are all free, and anyone can see them at any time.
Yeah, it's pretty amazing the amount of content that's on YouTube. Obviously, you and I are old enough to have grown up without the
Hmm.
internet and without YouTube. And now the kids these days, they have more content at their fingertips than they know what to do with. My kids probably right now are somewhere on their iPads watching YouTube Kids, just watching. We try to keep it educational. We try to keep it
Hmm.
in a funnel towards learning about the planets or dinosaurs or something like that. But the amount of content that's out there is staggering. So specifically when you narrow it down to podiatry, there's a lot of content out there as well. So what do you think kind of set yourself apart from all the other content out there and drove your popularity? What made you go from, a few hundred subscribers to most recently 580,000 subscribers?
I think, well, they say if you follow the YouTube creators, they tell you to niche down. Like your topic should be very narrow. So while mine is, it's not. And what I mean by that is it's all medical, it's all foot related. I don't dance. I can't get on there and do like TikToks where I'm dancing.
Ooh,
I've
imagine how
tried,
popular you'd be if you were on there dancing. Actually,
I don't
maybe you'd have
know.
no followers. I don't know how good you are at dancing.
I'm Italian. We can't dance. So what I kind of did was I tried to hit every population with that same niche, meaning if you're not a podiatry resident or student or you have no medical background, you'd still want to watch my video to learn. So I always tell people that are interested in doing what I do, when I create a video, I'm creating it for three people: a resident, a surgeon, or like a student that wants to learn from this, from the video, from the medical aspect,
Hmm.
a patient who is having that procedure done or has that problem. And then the third person are the weirdos that just like watching gross medical videos. So
Yeah.
when I'm talking, I don't use big terms like hallux valgus or intermetatarsal angle. I may throw them out there, but if you're a surgeon and you want to watch my video to see how I do a bunion, you don't need to know those terms because you already know them. You know what I'm doing.
Yeah.
A student will pick up on it. The layperson will understand what I'm saying if I speak in layman's terms. And then the third party or the people, the gross people, they just want to see the content. So they really don't care. So I've tried to focus on that, and it seems to have worked better because I'm targeting a larger audience in that niche. And then I've also branched out into doing shorts, which are just like where I'll do cuts, like grab videos that other people have posted and talk about them. Sometimes I'll get done doing, for example, we had a plantar plate repair case that went really well, and I'll go home that night and upload it, grab all the clips and put it into a 1 minute video so that other people can see it.
Sure. Do you think so? When did you start doing YouTube? What year?
It was about a little over 10 years ago. I think it was 2012. I uploaded my first video. I could be wrong,
Yeah.
but I really didn't go full force until about 6 years ago. And I was still doing the surgical content, but about 6 years ago, my friend Rick, that I was talking about, I remember where I was sitting. I was in the parking lot with my son, and he called me. He's like, dude, you need to get on TikTok right now. I was just talking to a plastic surgeon that puts his plastic surgeries on TikTok, and he's gone viral. So I went home that night and uploaded 3 TikToks, and I learned the power of short form.
Mhm.
And then when that took off, I started doing it on Instagram. And then from there, once YouTube allowed shorts to become, then I started putting short videos there.
Do you think if you could choose the key and you could only choose one, would it be the consistency of posting videos or the volume of videos? Do you try to put as many as you can, or do you post like one per week or two per week or whatever it may be? What do you think is your strategy when it comes to that?
I try to post consistently. I try to do shorts daily or maybe 5 days a week if I can't do daily.
Mhm.
But sometimes, I'm torn because I think sometimes if I'd put more focus into making a better short and maybe only doing three, it might be better than doing 5 to 7 mediocre ones.
Sure.
And then I try to just do long form whenever I can. And I wish I would do more long form, but when I focus on my long form, they take more time and then my consistency goes down. So I'm not putting my shorts up as much. And then I think my channel would become stale. So I just try to post consistently. It's become a daily, I do it every day. If I'm
Sure.
not posting, I'm working on a video. And burnout's a problem. You have to be careful because there are nights, Jeff, where I'll go to bed like, this is stupid. I'll fall asleep editing like, this is stupid. I don't know why I'm doing this. I'm done. And then the
Mhm.
next morning I wake up and I'm like, I got some cool content from this week. I can't wait to scrub through the
Yeah.
videos to see what the OR stuff looked like. Cause everything I do, every OR is being recorded. And in the clinic, most of my clinical cases that are interesting, I record.
Are you recording it? Who's doing the recording for you?
So I wear a GoPro on my head. I have the Ray-Ban Metas that I'll use, and they're okay, but they're great so that I don't miss anything.
Mm-hmm.
But my GoPro is my main thing in the OR, and then in the office, my students, it's been amazing to watch the evolution of 5 years ago, a student had no idea how to record something. Now they're in close, they're moving it around to get all around the foot, like they just know how to do it. And truthfully, they love it because instead of standing in the corner watching me do a ingrown toenail, because some of the students, I'm not letting them do a lot of stuff in clinic. It
Yeah.
varies,
Yeah.
by their fourth week I do, but
I
they'd
don't let
rather
them
be
get
right.
anywhere near the patient. I'm like, you stand over there. Maybe I'll have you be in the hallway. Crack the door so you can listen.
Right. So now when they have a camera, they're excited to get closer. I was getting made fun of at first, and now they're like, oh, if you go there, it's cool, man. You're always recording, you're always doing something. So we have a lot of fun with it.
Yeah.
And the patients actually like it because, especially an ingrown toenail, if it's a kid that's in junior high or high school and they had their ingrown toenail done by me, they go show all their friends. And then when their friends get ingrown toenails, they don't even know my name. They just know me
Mm-hmm.
as the YouTube guy, the podiatrist on YouTube. And their
Yeah.
friend sends the video and then they come to see me. It's
Yeah.
crazy.
That is funny. You mentioned burnout. I think that's an interesting part of this because sometimes, I do this podcast and it sometimes feels a little monotonous, or sometimes you rather just sit on the couch and watch a football game and not, do another episode. And then other times you're like, no, this is fun. I'm having a good time. But sometimes it feels like you're on the hamster wheel of just like, okay, how do I know when I'm done? Is there ever an end? Is there ever just like okay, now I've done everything I wanted to do? Or is it just kind of this ongoing, more of like a flowing river where it just kind of takes you where it takes you? How do you kind of rectify that in terms of like, as long as you feel like you're happy doing it, then you'll continue to do it? Or how do you feel about that?
This is a great question or a great lead into what I'd love to talk about. So, I've always had an interest in multimedia, computers. In fact, before podiatry, my goal was to go into computer science. I didn't know what I wanted to do, and I wanted to do something with computers because I just love technology. Well, my
Mm-hmm.
family pushed me towards physical therapy slash athletic training, and then I went into podiatry from there. But I've always had a love for music, videography, cameras, that sort of thing. So finally, this is an era in my life where my profession has bisected my hobby.
Yeah.
So when people say, "You mean you sit down at night and edit for a couple hours?" Well, I enjoy it. Like if before I was editing for my profession, I would be tinkering on a computer, learning how to maybe program or downloading different things, or I don't want to call it like hacking, but before MP3s and Napster, if you're familiar with Napster came out, we were
Mm-hmm.
we were sharing albums and live recordings through FTPs, which are file transfer programs. So I've just always had a love for being on computers, and that was instead of watching a movie or a sporting event, I would tinker on the computer. So now that passion has kind of bisected with what I do at work. So when I'm sitting down editing, it's kind of like an outlet for me. And my son is a YouTube editor. He's 20. He's in college now, but he has a full time job editing. So it's kind of a family thing. We talk strategy together. It's on the weekends we sit down and edit together, so it's kind of fun. The burnout comes not from needing content, not from doing it, but there's just some times where it's like, so there's a creative component to all of this, right? You can record a video and then edit it, but there's a creative component on what do I think the viewer wants to see and what part of this do they want to see. And if I don't have that creative energy, that's when I get frustrated.
Mm-hmm.
If that makes sense.
Yeah. How do your patients respond to you wanting to film everything? Because I do social media and post a bunch of cases, tell them, hey, I'm going to potentially put this stuff out on the internet. I use it to teach students. I have a form I have them sign that says, hey, basically, here's your understanding of what's going to happen with this. It won't include your name, your face, your date of birth, any way to identify you, anything like that. How do your patients feel about that? And do you get much pushback when you start talking about that or come in with a camera on your head?
So, in terms of what you just said regarding consents and HIPAA, we follow all of that. But to back up a little bit, when I first started doing this, I thought, I'm either going to scare all my patients away and them saying, I'm not going to that guy because he's not focused on medicine. He's filming and
Hmm.
that's not a doctor if he's on YouTube. That was my fear.
Sure.
And it's been the complete opposite. People are coming to me because they know who I am, because they saw me on YouTube. I had a lady today that was in for a second opinion. She was told she had a hammer to it. It was like a plantar plate. Well, whatever. That's not the point of it. But she came to me for a second opinion. I'm like, so, well, who sent you here? She's like, honestly, you popped up on my YouTube channel, and I just thought, wow, this guy sounds like he knows what he's talking about. He seems confident. I'm going to go see him.
Hmm.
And I'm hearing that now almost a daily basis that people are finding me that way. Or if they haven't found me that way, like, so I'm known for the MIS bunions in my area. Their friend might have had their bunion done by me, and they'll say, "Go check him out. He's on YouTube." And then they learn who I am, and they feel
Hmm.
comfortable coming to see me. So it's had the opposite effect.
Yeah. See, I was going to ask you a question about finding time to do this. I think you already answered that. When you become passionate about it, it's not something that you have to make time for. It's something that you're actually excited to do, especially if you're doing it with your son, because
Uh
there's
huh.
only so many hours in the day. And you think, well, I spend all this time practicing podiatry, and then I get home at the end of the day and I'm talking about podiatry like I am right now after I
Hmm.
did the same thing, so I can kind of relate. But when you become passionate about it and when you become something that you actually enjoy doing, then you don't necessarily have to make time for it. You almost have to potentially make time to not do it. Do you ever think about that in terms of like, all right, I got to set my phone down, I got to shut my computer, I got to turn all this stuff off and disconnect for a little while?
100%. And if you don't, it's like anything. If you like to eat and you eat too much, you get sick. If you
Yeah.
like to run and you run too far or too much, it wears you down. Another analogy that I'll make is people who like to golf, but know that they'll never become a professional golfer. And one might pose the question, why do you go out for 4 hours every weekend in golf if you know that's well, they're trying to get their stroke a little bit or get their score a little lower, get shoot into the 70s or shoot into the 80s, whatever their goal is. It's just like if I could get that next video to go viral or that next video to get 10,000 or 20 or 30,000 or whatever how many views, that's what keeps me going and it's exciting. And people say, "Well, are you making a lot of money on this?" There are videos I might make 10 cents on and I put hours of work into, but it doesn't matter because my presence is there, it's built my practice. It's helped establish my name, and it's done more than I wanted it to do. So I'm not trying to hit a home run in terms of money on a video. I'm just trying to keep the ball rolling.
Yeah, and I that spins me off into another question or another angle I was going to take this, because responsibility is probably too strong of a word, but you are a representative of the field of podiatry. You know, there's only so many people who are well known in the public in a certain field, right? Pimple Popper MD is maybe the most popular. I don't know if she's a dermatologist. I actually don't watch the show, but you understand my point. If you
Mhm.
are a representative of the field, so how do you view that you are a representative of podiatry, and how do you, try to formulate that and help maybe utilize that to shine a positive light on podiatry from your standpoint?
I guess I didn't realize it until Kent State reached out to me. They wanted to film a mini documentary because they learned who I was, saw what I was doing, and they're like, "You make this look cool." Some people don't realize what podiatry is. We want to use you to be the face for Kent State so we can draw in more students. And I'm like, Why would you pick, like, where did this come from?" They're like, well, we did a search, chat GPT, and you kept coming up. So we started watching you, and that's why we came to you. And I was excited about it because it's fun. I always say if there's a camera on, I'm excited. Not because I want to be on camera, but it's fun. I love to talk. I love to talk to people, and I love that creative energy. I used to get nervous about presenting. Now I love getting out in front of crowds of people because it's fun to talk and share my story. I mean, I love socializing. I think as physicians, we're good at talking to people because we put ourselves in an environment where we have to learn everyone's personality and interact with those people.
It doesn't mean everyone's good at it. I've met plenty of student or resident who is not good at talking to people. But yes, in theory, and I'm sure they will practice and I'm sure they will get better at it, but not everyone in the field of medicine. And maybe those are the ones that go into radiology or pathology, so they don't have to talk to the patients.
So I guess, being that I like to socialize and talk, I guess that helps me to continue to do this on YouTube or these outlets. But I love what I do. I mean, I love podiatry. I love the interesting cases that we see. Every time I do an ingrown toenail, I get pumped because I can't wait to. I know this sounds, but can't wait to twist that nail and watch it pop out, and it just never ends. And then I always think this is going to be a great video, and then you know what happens, Jeff? Is I walk out of the room, I see something else that's interested, and then that video gets put on the shelf, and I don't know when I'll get to it again. And that's
Yeah.
where I struggle. Is I'm not good at organization. Like I wish I could organize all these videos. I wish I had help. I wish I could keep a list and say, edit this cyst that we drained. This one's going to be a banger. It's awesome. The patients love it. When I get done draining a cyst and we show them in front of them the synovial fluid, and they're just mesmerized. And so
Mhm.
we've kind of taken what we do, and instead of that patient being fearful to come in, now they're excited to come in because we make it a fun environment for them.
You want to hear a crazy story? I might have to
What?
edit this out. I'm gonna tell. I'll ask my wife permission if I can leave this in. We were not
Go for
filming.
it.
We were not filming. We were in residency and we drained. So Pittsburgh is full of some interesting folks, many beautiful people, wonderful people, but some odd ducks. And we were in a room and a patient had a ganglion and we drained the ganglion and then we set the syringe down on the table and we turned around and we were getting the thing ready to get a specimen. And we looked over and the patient had squirted it onto her finger and tasted
No.
yes. Many people, or at least my attending, can vouch for the sincerity of this story. Tasted the ganglion fluid, and I think our jaws were just on the floor like, what just
Oh.
happened? It was crazy. So, if you're always filming, maybe you would have got that. And then that could be maybe viral video number
That
one.
would have been awesome. That's how you can start this. That's how this is going to start.
I need to find that lady. That's my key to success.
Was Mance there when you were there?
Yeah.
He was a character.
We had a lot of characters, yeah. Especially this lady who tasted her own ganglion fluid. Yeah. That was a wild one. That was a wild day. What do you think makes for a most popular video? When you, like you said, you spend all this time and effort and you make this video and you're like, this one's going to be great. And then it flops. And then you make another video and it takes off and maybe you expected it, maybe you didn't. But what are things that make for the most popular videos? And are you able to somewhat predict that ahead of time?
What I think is cool, and what we all think is cool, is podiatry. The general public doesn't. So you might do a triple arthrodesis and have awesome footage and get great correction, and nobody cares. But when
Right.
you cut someone's toenails that haven't been trimmed in 2 years and they're crusty and scaly and flaking off, that's what people love seeing. And I
Yeah.
think the story behind it adds to it. So when like, we had 2 of them today, one let me film and one didn't. And when I do it, I try to make it sound like it's educational. Like, don't make fun of this person's toenails. This 80-year-old mom was afraid to show their children what her nails look like. And now that the children has seen it, they needed to bring them in here, and there could be other people out there. So that's how I kind of portray it. And some of my viewers say I don't know how to cut toenails, and I crack up. I'm like, the patient's thrilled. They're hugging me when I'm done because somebody
Right.
did this. And my viewers are saying, he's rough. He didn't do this. He didn't do that. And I mean, you just have to laugh.
That's an interesting path that I didn't necessarily plan on going down. But if you get popular enough, there's always going to be haters. There's always going to be negative. Even I don't have that many followers, but there's always one person that goes through on my videos and gives it a thumbs down. I'm like, who is this one person that has all the time in the world to go through and be like, you watch the video and then you thumbs down? Like, I don't know. It just is absolutely bizarre to me. But like, there's always going to be haters. How do you handle the the noise and the comments and the people who are,
So
glass half empty people.
yeah. I've learned not to comment to those people. One, because if you comment and get yourself into one of those, you go down that rabbit hole of bantering back and forth.
Yeah.
They're not rational thinkers, one, and then they're
No.
just going to raise your blood pressure.
Yes.
So my son always helps me. He laughs at them. Like I'll grab him and say, Joey, look what this person said, and we'll laugh. And because
Yeah.
it's any comment is going to help you. So comments are good. So I had one this week on Facebook. I was in a bunion chat room and I was responding to someone. And I don't always respond in these, but sometimes I do. And someone wrote back, that is borderline irresponsible for a doctor to leave that comment. And I'm like, well, who are you first to tell me that and I didn't respond, but it's
Yeah.
like, I'm just trying to help someone. I gain no financial advantage by helping someone in the other part of the United States by just offering a simple comment or a suggestion to them. And then other people have to chime in. So those people are everywhere.
The internet is good and bad. We used to only have to hear from the intelligent people, the college professors. You read a book, you watch the, news, and they're interviewing some smart person who invented something. You used to only have to hear from the smart people, but the internet and comments have given a voice to the less educated among us. And it seems to be just ever present out there. And, sometimes comment sections are funny, and sometimes it's just an absolute kind of abysmal, disaster of humanity. And you're like, are these real people? Do you really think this? I mean, it's kind of depressing sometimes. So I can imagine not spending much time in your own comment section for some of these videos, just because, you're going to get the good ones and you're going to get the bad ones with it.
Right, right.
So if you had to summarize your most popular videos, they're the kind of the shock and awe, the cysts, the nasty ones. Those are the ones that that seem to resonate.
The pus and the toenails. Yep.
People love it, man. People
It's
love
crazy.
it. Well, speaking of minimally invasive surgery, we talked about that for a little bit. You want to jump into a few cases here and get your thoughts on these?
Sure. And I gave you these because I just thought, hey, these are great talking points. It'll show you where I'm thinking when I go into some of these cases. And I think we could just go from there. If you have questions on why I chose what I did. And as I had my students pull some of these, I told them, I go, one of these, this one looks very bad. Some would say this would be malpractice when you look at the x-ray. And I'm showing this because that same person a year later came back to do the contralateral foot because they were so happy.
Yeah. I was just on another podcast that I do, and we had decided that it doesn't really matter what the x-ray looks like. We as physicians get caught up on what the x-ray looks like, but the patient doesn't see the inside of their foot. They see the outside of the foot and they feel how it feels. And when the outside of the foot looks good and the foot feels good and they're able to do all their normal activities, they could not care any less what the inside of their foot looks like on x-ray.
Jeff, thank you. Please, every time you do a podcast, please start that and end it. And start the video and end it with that so that our colleagues start to think that way and we can collectively think that way. It's not just the x-ray.
Yeah, absolutely. So I don't have all those cases in here. I picked maybe a select couple just that I thought would be good talking points. So, I mean, I'll let you kind of take this here, but just anyone who's just listening, we have a pretty significant hallux valgus, bunion deformity, increased first intermetatarsal angle, lateral, hallux deviation, and kind of some windswept lateral deformities of the lesser digit. So these are tough things to tackle. So when that first x-ray, that the one on the left comes in, what are the first things you're thinking about for this patient?
I have to collect my thoughts because I get so excited about talking about these.
You take your time. We're good.
So let's start with the x-ray on the left. So she comes in and she's basically there because she wants her bunion fixed.
Mm-hmm.
But when you look at it, you know that if you move the first metatarsal, let's just say you pick a lapidus and you move the first metatarsal over, it's going to bang up against the second metatarsal because there's that metaductus component. And that's something I always struggled with in school and in residency and studying for boards when they said, well, what's the true IM angle? Because the metaductus comes into play and that's not the true IM 1-2 angle. And I never understood that, or not that I didn't understand it. It just didn't make much sense to me. Like, who cares if it's true or not? Our goal is to get the toe straight.
Hmm.
So when these people come in, if you say, we're going to take your bunion and we're going to move it over by fusing your first metatarsal to one of the square bones in the midfoot. And then all these lesser metatarsals, they're at a bad angle. So we have to cut and move all those over and then fuse all those joints. And now you've stricken panic among them. And they just came in because they thought you were going to shave the bump down on their big toe. And now you're talking about fusing their whole midfoot. If
Yeah.
they ever come back to you again, it'll be amazing. That was the problem that I always had. So when I started doing it minimally invasive and I was learning the power that you had to do small osteotomies to the lesser mets and you could realign the MPJ, and I was seeing what others were doing, especially Dr. Siddiqui, and we were kind of working at this together. And I'm like, well, that's pretty impressive. We can cut that second med head and move that over, and you're getting metaductus correction as opposed to just fixing their bunion. Because in this same x-ray, when I first started in practice, I would do a lapidus on this and it would fail because I couldn't get the correction that I needed. And the second metatarsal still in the way because I didn't do the metaductus correction. And now introducing this, the recovery time is amazing. I mean, these patients have no scars. They have no, I mean, yeah, they do have post-op swelling because you're making multiple osteotomies, but
Sure.
it's way different than when you have those multiple linear incisions over the lesser metatarsals. So you're not scaring the patient. You're getting amazing correction and not just the bunion, but the forefoot and the metaductus. And what also is amazing is we would almost call these hammer toes when they're abducted like that, but they're not. They're just dislocated at the metatarsal phalangeal joint. So as you're swinging the metatarsal lateral, you're pulling the lesser toe over, realigning the MPJ, and the toe is now sitting straight. So it's pretty amazing correction that you're getting. And some of these patients don't even need capsulotomies. Some of them do, depending on how severe it is.
Yeah, the deformities that I think at least will limit it to forefoot deformity and exclude
Hmm.
hindfoot and Charcot for a minute. But some of the most complicated forefoot deformities are those, like you mentioned, when there's an increased hallux valgus in the setting of metatarsus adductus, because there'll be times where one deformity is blocking the correction of an adjacent deformity. And then your patient comes in for your, like you mentioned, I'm going to drill down on that. They come in because their big toe joint hurts, and all of a sudden you're talking about like, well, we got to move this and this and this and this and this. But ultimately, when you see that foot on the right and the bunion is corrected and the toes are straight, and you almost have to do all of that stuff. Otherwise, I think that they may not have a fantastic outcome. But it is a little bit of an interesting conversation with these patients to try to describe, well, if we just work on your big toe joint, we could do that, but here's what might be the issue with that. And so that can
Hmm.
complicate things. Jumping ahead to the 5-month post-op there, I think it's amazing. And I've seen it time and time again from lots and lots of people's x-rays about the healing that occurs the metatarsal neck osteotomies, and the amount of healing that occurs with these is just it's amazing what the human body is capable of.
It is. It's and the X-rays look weird. And what I like to do, I'm going to do this, and you're not going to see it, but when some of my naysayers or colleagues criticize these, I'll take my hand and cover up that proximal 2/3 of the foot and say, "Well, you don't even see what we did, and you would agree that the metatarsal phalangeal joints are rectus and in a normal anatomic alignment. But the minute I pull my hand away and you see then you criticize." So but when you look at the foot and the patient's happy, they have a normal foot, and it was all done minimally invasive.
Yeah, those same people who are leaving negative comments on your YouTube videos, they exist in the real world too, and there will be people who criticize. So, it's the nature of everything, and everyone thinks that they are correct in their own belief
Yeah.
system of what an X-ray should look like or what procedure is the correct procedure. And I don't think anyone's to say who's right or wrong, but what I've said before, because I jokingly criticize these X-rays as well, But what I truly believe is when you look at that picture of the clinical foot on the right and that patient walks out and they're happy, that's all we should ever care about, is that they came in with pain, they walk out with no pain, and you've helped them. That's really all that matters.
100%. You know, some of these, and I think I included one of them with you, the way that the second metatarsal heals and calluses. I remember one of them popped up when I was looking to grab their contralateral foot, and I'm like, oh my gosh, what did I do to this patient? And then when I went in to see her, she's like, "Thank you so much. I love my new foot." But when I look at her X-ray, I'm like, "My God, it looks terrible." You know, I even forgot what it looked like when I got
Yeah.
done. But when you look at her foot clinically, the toes are rectus, they're not contracted, they're not abducted, and she's happy. Or she's there a year later to do the other side. I mean, that's what really made me think, man, you're right. The human body is amazing how it can heal itself if you just give it a chance.
So next case is a 68-year-old female with, again, probably even not probably more severe metatarsus adductus here. So again, this is one of those tricky deformities where, some people would advocate for a lapidus, but what are you going to do with the second metatarsal? Some people would advocate for a first MPJ fusion. But what does that conversation look like with this patient? Hey, I think we can fix this without sacrificing joints and not fusing them.
Yes. So if their midfoot is not painful, the question that I will routinely say is, I want you to take one finger and point to why you're here and what you want me to fix. If they're pointing to their midfoot, then we have a different conversation.
Sure.
But the overwhelming majority of these patients are pointing to their bunion, the MPJ, and saying, "This is where all my pain is, and I want this to go away. Can't you just shave it off?" And then I'll pull the X-rays and try to educate them, and explain how it's dislocated. And then, being that I take photos of everything, I'm fortunate enough to have photos of other patients that I've done these on and say, "Look, this is their immediate post-operative foot. This is what we need to do to get you there. It's not going to be as bad as you would think." And then they start to understand it more, especially when we show them where we have to put the joint to reposition the toe. But it is a challenge. It's not something where you walk in and say, "Yeah, we're going to fix your bunion. We'll get you scheduled." You have to manage these patients with a little bit more time and use pictures. I use a lot of pictures of real cases and real feet to show them what we're doing.
When you look at that X-ray, the first X-ray on the left, is there
hmm
anything that you would see that would change your mind about performing MIS head procedure and convert to maybe a first MPJ fusion? Is there anything you're looking for that
Yes.
would change your mind?
So good question. So 10 years ago, I would have looked at the same X-ray and fused it. 5 years ago, I would have looked at it and said, "Man, I'd love to fix this minimally invasive, but I wonder what would happen." And then
Mhm.
I would have fused it. Now, when I see these, I tell my residents, I can't wait to see how far we can shift this and what we can do to get the toes straight.
Yeah.
Because now I have the confidence going into these, knowing that you can pretty much make these osteotomies and shift and push and move and get the toes where you want them. So what I'm looking at in the great toe is, if it's gliding and moving and there's no crepitus, I'm going to try to realign it. If it's really grinding and I can't dorsiflex it and I really feel that the cartilage is gone, then I'll talk to them more about a fusion. But even in some of those patients, and what's hard too, Jeff, is you have to understand a lot of these people with this particular type of deformity are coming to me and telling me I'm here to get my bunion fixed minimally invasive. So they're coming in already knowing what they want. And then if I'm going to tell them we have to fuse their joint, they're kind of turned off. So I'll have the conversation and say, I can try to fix it minimally invasive. I'm moving your joint and I'm getting a little resistance. It's grinding a little bit. Your x-ray shows the narrowing. We
Mhm.
can do it, but if it fails, you might need a fusion. And they're okay with that. But if there's some that you can just tell, you move it and you're like, I can't. You need a fusion. But if it's questionable, I'll have the conversation with them and they understand that it might need fused down the road.
Sure. The only thing that makes me a little bit nervous is when you have that angular deformity. And so picture the first or the medial aspect of the first metatarsal head cartilage is uncovered. And if we've done, talonavicular joint fusions in a severe flat foot, you realize that the way the cartilage strengthens itself is due to force and usage. And
Mhm.
that medial aspect of the cartilage has not been used in such a long time. And you swing it over, and then they are starting to use it. I guess you don't know until you swing it over and let them start using it, whether that cartilage is going to be sufficient for them to ambulate without pain. So, like you said, having that conversation ahead of time, hey, I think we can do this, but there's always a chance, we can't predict the future. We may need to adjust course in the future.
Correct. And I'll tell you, some of those patients, Jeff, when they come back 6 months, a year later, and I'm moving their joint, I'm like, crap, I can barely bend it. And they're like, yeah, I don't mind that because the bump's gone. They don't have pain. The motion's lacking, but it's not painful. They're just
Hmm.
happy that the bump's gone. But
Sure.
when I look at it, without them talking back to me and I'm moving and I'm in my head, I'm like, oh, great. They're going to be upset because there's no motion.
Sure.
Some of them aren't. Some of them are okay with that.
Sure. Oh, the dreaded crossover toe. This is like my nemesis, everyone's nemesis, 68-year-old female with a crossover toe. So when you see that picture on the left, when they come in clinically, what's that conversation look like with that patient? Because this is exactly the patient I was talking about. Maybe in this patient, maybe their bunion doesn't hurt. Maybe it's just the second toe. And they come in, they say, my second toe is rubbing on my shoes and it's really hurting. This is exactly what I was thinking about when one deformity is blocking the correction of another deformity. What are your thoughts, and what's that conversation look like?
Yep, I had it today and it didn't go that well because the patient, this was her second visit with me in the last year, and she has that same exact foot that you're seeing there, except this patient's I think in her 70s. She might be 72. She only has pain to the second toe. Now the bunion isn't as bad as this one, but she keeps saying, "I don't want my bunion fixed. There's nothing wrong with it."
Yeah.
And I explained to her, I'd be willing to just fix your second toe, but if I push the second toe down, it's probably going to pop back up. Your third toe is in the way. So if I can get you to agree to the bunion and I fix the second toe in the bunion, your third toe is going to be in the way.
Yeah.
So I explained to her, I'm like, we have to do your bunion in at least 2 and 3, maybe not 4. I said, if you don't want all that work, the simple thing to do is to amputate the toe. No, I'm not having the toe amputated.
Yeah.
And then I
100%. I agree with you.
Right. And I reminded her, I'm like, I don't want to amputate the toe, but you don't want me to do what's, and we went back and forth with it in a very friendly manner. I try to explain that it isn't the bunion that hurts. I agree with you. It's where the big toe is from the bunion. So
Yeah.
it's if you don't have the patience to talk to these people, it's challenging.
Whenever I can get this patient to agree to a second toe amputation, that is the easiest, most direct, pain-free outcome for them. And so the patients that do that, I will say, are extremely happy. And sometimes they come in and they say, I should have done that 10 years ago. But there
Yep.
is a mental hurdle there that some people are like, I've had some people come in and suggest it. Can you just take the toe? I'm like, yeah, we can do that right now if you want.
And you know
That's
what they
easy.
ask me, Jeff? They're always worried about balance. They're like, well, won't I lose my balance if you remove my second toe? And I'm like,
Yeah.
it's not doing
Right. That
anything
thing
for
is
you right now.
flying through the air. That thing's not even sniffing the ground, let alone touching the ground. Yeah, that is
Right.
not affecting your
Exactly.
balance one bit. But for the sake of completion, talk through what you ended up doing here with this patient.
So I have on there plantar plate question because if this toe is symptomatic plantarly, where the plantar plate is, then I'm probably going to open it. And what I would do is an MIS bunion. I would open up the second toe, repair the plantar plate, pull it back down with the wile, like not the plug arthrex, but that scorpion technique is how I usually do it. But if it's not painful, if it's just simply dislocated, then what I typically will do is shorten my second metatarsal,
Mhm.
minimally invasive. And I've gone through different versions of this. I tried doing a reverse wile so that the metatarsal would go dorsal and proximal. But what would happen is it would kind of rotate and the spike would be palpable.
Mm.
So now what I'm doing is I'm just cutting the metatarsal with the burr perpendicular to the long axis. And I keep cutting it and shortening it on itself until I can decompress the joint. And then I'm pinning it through the toe and into the second metatarsal. And then in this case, we actually had to move the third metatarsal over laterally to get it out of the way. So sometimes I'll do a little bit of both, move the second metatarsal and third laterally and shorten it at the same time. But you might say, well, how do you know what you're doing? Like you're saying, shorten, move it. I'm moving it to try to get the toes rectus. And when I can see it starting to become rectus, I'm pinning and pushing the met head in the direction that's allowing that.
What order are you going in? Because sometimes you can't put one where you want it till two's out of the way. You can't put two where you want it till three's out of the way. Are you working lateral to medial? Or are you kind of doing all your osteotomies and then kind of manipulating? Or how are you ordering that?
So that is a great question, and I remember how I learned. And I'm a very transparent person, and I'll tell you what happened. The first time we did one, I had planned on doing 2, 3, and 4. And to elaborate a little bit, I kind of look at metaductus as a second and third metaductus or a 2, 3, and 4 metaductus. Most of them are just 2 and 3.
Mhm.
Some of them are 2, 3, and 4. But the first case we tried to do this on, and I say try because these are sometimes experiments. We don't know where the correction will go. I planned on cutting 2, 3, and 4, but I only cut 2 first and was trying to shift it. And then I remember my resident Sydney saying, "Well, Campy," they call me Campy, like Campy. You remember that deep transverse intermetatarsal ligaments there? You need to cut them all, and then it'll move. And then we cut the other ones, and everything just shifted right where it wanted to go. So
Yeah.
I would advise if you're out there listening and you want to do these, and you think you have to move more than one, cut them together because your deep transverse intermetatarsal ligament is going to
Yeah.
kind of prohibit that.
Sure. So really good outcome there, nice and straight. And again, you look at the X-ray, and you've got some angled bones, but you look at the clinical photo, and straight as an arrow. So, all right, let's do one more here. So, 62-year-old female, metatarsus adductus, again, big bunion, lateral windswept deformity, and again, tackling those multiple lesser metatarsals. So, talk about your technique on this one specifically of translating the metatarsal capital fragment of the lesser metatarsals laterally and then pinning down the medullary canal
Yep.
versus like pinning it in place. What is your thought process for that?
Yep. So here's what we do. We do the MIS bunion, cut it first, then I'll cut second and third through that same incision for the bunion. Because if I know I have to get to 2 and 3, you can usually move your burr all the way across. So I'll cut 2 and 3. Because if you look at this x-ray on the before, this is just what I talked about. This is a metaductus 2 and 3.
Mhm.
4 and 5 are normal, 2 and 3 are in metaductus.
Sure.
So we'll cut 1, 2, and 3. I'll fixate my bunion. And while I'm fixing the bunion, it pushed the second lateral. So then when I pin the second, what I'm doing is I'm doing it all by hand. I don't even have the wire in my gun. I'm trying to manually insert the wire adjacent to the medial aspect of the proximal phalanx, grab the head of the second metatarsal, force it laterally, and then if you can grab the capsule with your pin and then stick your wire into the medullary canal, that head will fall lateral right where you want it. And then you put your gun on and advance the wire into the base of the metatarsal.
Mhm.
And then I'll do the same exact thing for the third. And what you're trying to do is just force that head laterally. But I found that if you don't grab the capsule of the head, then it'll either rise dorsal or plantar, and you're struggling with that. So you almost have to like feed the needle into the capsule to grab the head and then push it over.
How long are you leaving those wires intact or in
I
place? I mean,
generally leave them in for 3 weeks based on that article Siddiqui had when they were doing their bunions with the Siri technique. So I leave it in for 3 weeks and then pull it. And that's usually long enough to keep it there.
sure. And then are you letting these patients walk on it, or what's your post-op
Yep.
protocol for something like this?
They're in a walking boot day 1. And I usually say you're going to be in the boot for 3 weeks. At 3 weeks, we'll pull the pins and then you're allowed to wear a running shoe. But I'll tell them these lesser met osteotomies will swell sometimes. So you might be in the boot a little longer because of swelling. But if you're able to, you can get into a shoe if the swelling doesn't prohibit you from putting it on. And sometimes squeezing it into the shoe is good because it pushes that swelling out.
Absolutely. All right, we're coming towards the end of the time here, so I'm going to stop sharing that. Thank you for sharing those cases. I think those are always fantastic for people to hear some clinical tips and pearls from someone who's been doing quite a bit of that stuff.
Thank you, Jeff. Thanks.
Absolutely. I want to thank you for hopping on tonight and spending some time with me and talking through all that stuff. I think it's fascinating, the YouTube aspect of this and the residency director aspect of this and the minimally invasive surgery aspect. So thank you for your time and thanks for joining me tonight.
Thank you for having me, Jeff. And please, everyone listening, do not stop listening to this podcast. It's where we need to go in our profession. It brings us all together. We can all get on here and chat. And I hope Jeff keeps doing this and for many, many, many years to come, because this is where everyone's profession is moving. Everyone's going online. Everyone's doing things like this. And I'm so proud to see someone out there start this and keep it going. Starting it's one thing, but you kept it going. And that's what's great.
So far, so good. So I appreciate that. Anyone listening is interested in your program, give a little plug for your program one last time. Give us the name, the location, and where they can go for more information.
Yeah, it's Western Reserve Hospital. It's in Cuyahoga Falls, Ohio, which is just south of Cleveland, not far from Akron. We take one a year. Students listening, we'd love to have you come visit. Even if you didn't do a clerkship here, just reach out to us. Heather Kennedy is our podiatry coordinator. You can reach out to her. My email is feet, F-E-E-T, @me.com. You can reach out to me, and we'd love to have you come through and visit us.
And anyone interested in checking out your YouTube or your TikTok, why don't you throw that out there as well?
Sure. You can find me on YouTube. It's @FootDoctor, or just type in my name on YouTube. I don't know my Instagram and TikTok handles. I think my TikTok is
Okay.
@Dr. Nick Campitelli, and I think Instagram is very similar. But if you
Google
just
him.
look up,
Google him.
yeah,
He's everywhere. You'll find him. Dr. Nick Campitelli. Thank you so much for joining me tonight.
thanks.
All right.
Glad to be here.
Thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dykes. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.